The patient in past medical history of patient is a known case of poorly controlled diabetes and hypertension for about 10 years. And for diabetes, she is on insulin, which is not very good compliance. She's on and off on insulin with HbA1c of about 8%. And for hypertension, she is using oral antihypertensive drugs. Her nephrology status is not known as she has not done any test for that, and there is no any past surgical or past surgical history of eye or any other systemic as well. On examination, clinical examination of patient, her visual acuity in right eye is hand movement, and in left eye is 636. The IOP of both eyes is 12, which is normal in range. Color vision for right eye is not appreciable as the her vision is too much diminished. But for left eye, it is normal. Amstel grid cannot be performed in right eye, but she has a complaint of metamorphopsia with Amstel grid. The corneal sensitivity of both eyes is reduced, and the extraocular movements are intact in both eyes. On slit lamp examination, both adnexa of right and left eye has meibomian capping. Conjunctiva is unremarkable for both eyes. Cornea is clear. Anterior chamber is formed deep and quiet. Pupils are reactive, round, and regular, and there is lens changes of about grade 2 cataract, nucleus sclerotic cataract, and anterior vitreous is also remarkable for her. This is a picture, fundus picture of her right eye. There is a vitreous hemorrhage in right eye. So we cannot see any fundal details in this eye. But for left eye, she has a PRP session 360 given for her, which PRP scar marks are visible on temporal side this and as well as supranasal side as well. And the superior arcade of the posterior fundus is unremarkable, but there is in supratemporal region of the arcade, there is a mild NVE still present. And but the inferior arcade is there is a dilation of the vein, retinal vein, with a slight of neovascularization as well in infratemporal region as well. And there's a vitreous hemorrhage. It's not vitreous hemorrhage, but pre-retinal hemorrhage is there in infratemporal. On macula, there is still small NVEs also present, and this is normal with the CD ratio of 0.4. And on clinically, it is not very much visible on picture, but clinically, she also has a macular edema as well. So that's the case for today.
Okay. Thank you, Dr. Sohaib.
Yeah.
Dr. Anuj, so you have any comments or in terms of how do we go about with moderation? You're muted, Dr. Anuj.
Yeah, so you can go ahead with some questions regarding the history, and if some points in the examination you feel missed, and then you can go ahead with the management, and you can keep the questions open for the audience as well.
Correct. Yeah. So it will be good that if it is an interactive session with the audience as well. So Dr. Sohaib, thank you first of all for coming forward and presenting a good case to all of us. So Dr. Sohaib, you are in which year now?
I am in 4th year.
Okay. So this is the final year for your, and you will be appearing for exams?
No, 4th year. They are 4 years.
Okay.
Final year.
Okay. So this patient, if you can go back to the systemic history of this patient.
Yeah.
So apart from diabetes, she is hypertensive also over the past 10 years. And HbA1c of 8%.
Yes.
Yeah. So what about her lipid profile or anything, any idea about that? Are you aware of?
No. These tests were sent, but the reports are not present. They are not here.
Okay, fine. Not a problem. Yeah. So the most important part I would like to say here that duration of diabetes is the single most important risk factor for development of diabetic retinopathy. Okay, so if we look at the epidemiological studies which are performed, okay, say the DRS or any of the diabetic epidemiological studies, around 23% of the individuals develop NPDR after 11 years. And that increases 60% of patients developing non-proliferative diabetic retinopathy at 16 years of their diabetic duration, out of which around 3 to 4% can turn into developing PDR at the end of 11 years. This is in spite of good control. Okay, so what we have to understand here is that 10 years of duration and patient developing a high-risk PDR in the right eye and left eye is post-laser as well. So duration of diabetes is the single most important risk factor for the development of diabetic retinopathy. Okay, yeah. So now here, it's also important to understand what is the fasting blood sugar level and the post-lunch blood sugar level. So now, if you can answer in terms of if the patient presents to you for the first time, what all investigations will you send for the patient? Others may volunteer as well.
For the first time, I would like the lipid profile, as there's association with it, and also I would like to know the renal function of this patient and the fasting blood sugar as well.
Okay.
This is for the systemic investigations.
Correct. Yeah. Apart from that, a CBC and getting to know the hemoglobin also is extremely important, because patients with renal or diabetic nephropathy can have anemia as well, and this can complicate the diabetic retinopathy.
The anemia?
Yes. Okay. Patients with having a deranged renal profile can also have reduction in the erythropoietin production.
Yeah.
Okay. This can also compromise the diabetic retinopathy status with worsening of anemia. Okay, so that is one condition which we have to think of. Now, in this patient, she is post anti-VEGF in both the eyes and post laser in both the eyes, right?
Yeah.
Okay.
Post laser in left eye.
Okay, right eye, no laser is done for her.
Yeah, because of it, it is not clear yet.
Previously, it was not done. Yeah. So, just to complete the risk factors, systemic diabetic retinopathy can be symmetrical or it can be asymmetrical. Okay, like in your case, it is a case of symmetrical diabetic retinopathy. Both eyes have developed at the same time. So the causes for symmetrical, can you name a few causes for symmetrical diabetic retinopathy? You or other residents as well.
Symmetrical or asymmetrical?
Yes. So symmetrical means both eyes have a kind of disease.
Usually in patient it is symmetrical because it is a systemic disorder. So it is usually symmetrical. But there are some cases like if the retina is atrophic, or if there is a high myope, then retina is not. It doesn't have that much potential or the vessels to cause the changes. That's why it's asymmetrical in these cases.
Very nicely pointed out. So what you mentioned are the local factors, right? The local factors which are responsible for asymmetric diabetic retinopathy. Okay. So the local factors, one involves is high myopic or anisometropia. In both eyes are high myope, both may not develop diabetic retinopathy. If one eye is normal, other eye is quite myopic, anisometropia might be present. That can be cause of local factor of asymmetric diabetic retinopathy. Patient having optic atrophy in one eye. Okay, that also will lead to a glaucomatous disc. Yeah, glaucomatous disc because of leading to optic atrophy or neototal cupping. That will also lead to asymmetry of diabetic retinopathy. So these are the local factors, some of the local factors. Whereas if we look at the systemic factors, so factors which are there, which increase the risk of developing diabetic retinopathy, symmetrical, are anemia, as you mentioned previously. Having significant nephropathy itself, like all diabetic patients will not have retinopathy as the first complaint. Some may have nephropathy as the primary complaint. So this can subsequently lead to a symmetrical diabetic retinopathy. So diabetic nephropathy can also complicate and lead to symmetrical diabetic retinopathy. Okay, pregnancy itself. Some people develop pre-pregnancy, they are diabetic, and the pregnancy can worsen, leading to symmetrical diabetic retinopathy. Hypertension. Rarely, thrombocytopenia and leukemias can also lead to symmetrical diabetic retinopathy. Whereas important causes of asymmetrical systemic factors which causes diabetic retinopathy are carotid obstructive disease. Okay. If only one side of the carotid is occluded or there is a stenosis there, the other side is going to develop a proliferative diabetic retinopathy. This may not progress in the same way. And other reasons, and simultaneously, similarly, other causes, obstructive sleep apnea. So these are the two most important reasons which cause asymmetric diabetic retinopathy, are systemic risk factors: carotid obstructive disease and obstructive sleep apnea.
How would obstructive sleep apnea will cause asymmetric?
Yes. So what happens during obstructive sleep apnea as well? Especially, it is noted that the left side there is a kind of a hypoxia which develops. So when the tongue goes back and you have relative hypoxia of the ophthalmic artery, okay, and an internal carotid artery as well. So it's just hypothesis, but that is what we have seen, that patients with obstructive sleep apnea are more predisposed to develop vein occlusion and asymmetric diabetic retinopathy.
Okay. I will see into this also. This is a new point for me.
Yeah.
Till then, can somebody tell us what are the studies for this systemic control making a difference in diabetic retinopathy? Can someone from the audience just tell us the studies? As Dr. Bhavik said, that control of sugar is important. So which were the studies which found out these results?
UKPDS.
Very nice. So what did the UKPDS say? Can you just conclusion, or what is the inference which we can take it for our case?
I don't remember the exact conclusion, but
no problem. Okay, so do you know the full form of that? Anyone else?
United Kingdom Proliferative Diabetic Retinopathy Study.
Okay, I don't think it is proliferative, but I also don't remember the name. It is prospective maybe, but I don't know. This maybe somebody can search. But as you said that study is not for our case, because that was for type 2 diabetes.
Yes.
Okay, so it is very important that you, for exam point of view and even for your that UKPDS is for type 2 study. So our case as is a type 1 diabetic retinopathy.
Yes.
Right, Dr. Soeb?
Yes. Yeah.
So what studies are applicable in our case?
This for this DCCT is a study for type 1.
So what was the inference, like in just general, not?
It says that with tight glycemic control, 76% reduction, there is a 76% reduction in the case of PDR.
Excellent. And what about hypertension?
Hypertension is largely studied in UKPDS study.
Very nice.
So the control of
conclusion in that?
I think there's a 23% reduction with the tight hypertensive control.
Yes, but in those cases, the hypertension was out of control. Okay, so if your hypertension is out of control and you control it, it may help in reduction in your severity and progression. But what was the latest study which was done recently?
For hypertension?
Yeah, for systemic control. Anyone else with the name of a car as well with the same study? It must be there in Pakistan as well, a Honda car.
No. Accord, I think there is a study Accord, but it is for lipid profile.
Yes, so it is for lipid profile, for tight sugar control, and for
hypertensive control.
So in that, they found that there was not much difference if the blood pressure is already under control and you are controlling it. Okay, so that is just
But if the blood pressure is uncontrolled and we control it, then it will reduce the
absolutely. So that it is very important. Like if your blood pressure is out of control, then definitely you have to control it. But if you have a patient who is a well-controlled hypertensive, if you are making him more bringing tight control, it may or may not lead to translation in reduction in severity of your diabetic retinopathy. Okay. Yeah, I think Bhavik can add, or he can go ahead.
I think from the exam point of view, a few studies are extremely important, like DRS is one, DCCT, UKPDS, and most remarkable or the study which has changed the entire outlook is the ETDRS trial. Okay, these are from the historical point of view. And what is more important, maybe we can come towards the end of the presentation or towards the end, we can discuss about it, is the drcr.net trials. Okay,
Yes.
Diabetic Retinopathy Clinical Research Network. So it can be a question itself altogether on one of the important protocols. If not, if you are not well versed with it, please go through the website. They have very short, very nicely concise aim of the study and the conclusion. This is itself is good enough. Okay.
But this DRCR control trial is related to the management of the diabetic retinopathy, I think, like lasers and anti-VEGFs.
Yes, partly management, but some of the protocols also have systemic risk factors. They are observational studies as well in that.
Okay.
Okay. Yeah. So since others are also there, let us start with a simple basic thing that. So I have a question now. Say a patient has just 2 microaneurysms. How will you classify that patient, that individual? So maybe apart from Dr. Sohaib, others can answer.
Very mild NPDR.
Okay. So what classification you are following?
Dr. Sadhana, maybe you can take the question. Yes, Dr. Sadhana. Are you available?
Okay, so I'm not sure of very mild NPDR because there are multiple classifications which are there. But from the exam point of view, if you can stick to one, that is the ETDRS classification and how they have classified, that will help everyone because they're all in the same page, even the examiner as well. So with only microaneurysms present, we classify it as mild NPDR. So microaneurysms are the earliest signs of diabetic retinopathy, and they may occur anywhere in the retina. Okay, so it is not just, it is at the posterior pole, you will be able to see it. They can appear anywhere in the retina. Right.
Yeah.
So can anyone tell me what is the size of a microaneurysm?
Well, the ETDRS not classify, but define it. It is about 125 micron. Lesion of 125 micron with its maximum length is defined as a microaneurysm.
Right. Okay, so microaneurysms are small saccular outpouchings from the capillaries. They were documented as early as in 1879, but it was only in 1943 that a relationship between diabetic retinopathy and microaneurysm was noted by Lowenstein. So it is the hallmark of diabetic retinopathy. And what you mentioned is the size of microaneurysm can range anywhere from 14 to 120 microns.
Okay.
Okay, and we call it as a macroaneurysm if it's beyond 125 microns. Okay, so now the next question is, where does this 125 microns come into the picture? This is a very commonly asked question in the exams.
Why 125?
Yes, you also said, right, 120 microns. So from where does 120 microns, 125 microns number?
It's the diameter of the blood vessels coming out of the optic disc. You can judge it with respect to that.
Okay, if you want to modify your answer further, it's a very good answer. Diameter of the optic blood vessels. Is it only the blood vessels or one particular vessel?
Vein, retinal vein, central retinal vein.
Correct. Why not artery?
For this, I don't know.
Because the artery caliber will keep on changing as per the age, as per the systemic hypertensive. Suppose the patient is hypertensive. Okay, the artery is going to become narrow. More or less, the vein size remains the same.
Okay.
Yes, in the normal individual talking about. That is the reason why for as a landmark, we take then the inferior vein when it exits the optic nerve. That is where we take the dimension and compare it, the aneurysm size or any other lesion which you want to compare with that particular vein when it comes out of the optic nerve. So what happens to these microaneurysms? What is the course of a microaneurysm? Like we see multiple times the same patient and we have documented microaneurysm near the fovea. Next time it is not there. Right? Some new microaneurysms have come up. So what happens to those microaneurysms? Any idea, any thoughts about this?
It can be cellular or cellular. If it's cellular, then it can leak and sometimes it gets clumped and it disappears.
Very good. Okay. So partly what you mentioned, if you want to put in a better language, they normally disappear over a period of 3 to 6 months time. They may either bleed or they may rupture. They can undergo thrombosis as well. Okay. Or just a capillary occlusion may happen. Some of them actually persist to exude, or rather like the fluid comes out of it for a longer period of time. Okay. Yeah. So Dr. Sohaib, in your patient, any OCT was done for that patient? You have any OCT picture?
No, I don't have that picture currently.
Okay. Okay. One important point I want to raise now. Have you come across, okay, what all conditions microaneurysms are found or noted? Apart from diabetic retinopathy, can anyone answer that?
Hypertensive retinopathy.
Okay, very good. Then, apart from that?
In CRVO even.
Yes. Okay. Apart from CRVO? Anything else?
In which?
Any other condition?
Mm.
Okay, even vein occlusions, DRVO.
Yeah.
Right.
Infective condition.
What? Sorry?
Infective condition.
Infective condition like in uveitis.
Before that,
HIV, sir.
Yes, very nice.
Yes. Okay, so though it is a hallmark of diabetic retinopathy, doesn't mean that all patients with microaneurysms have diabetic retinopathy. So it's very important to understand and take the systemic history and relate to it. Even SLE can have microaneurysms, right? SLE retinopathy. Microaneurysms spreading very rapidly. It can be because of radiation retinopathy as well. Sickle cell anemia can have microaneurysms. Okay. So why I'm coming to this point is, you mentioned that there are microaneurysms in vein occlusion and diabetic retinopathy. Is there a relationship between the size of microaneurysms in these two conditions? Has anyone thought about it? Is it, can I share a slide? Is it possible, Dr. Anuj?
Yeah. Go ahead. So I feel lucky that Bhavik is not asking me those questions. I hope not.
Recording.
Yeah, just a moment. My computer is, so that's why I connected my phone as well. Just a moment. Dr. Anuj, I'll request you to please add me into the Zoom again through my computer. Yeah, can you guys hear me? Hello?
You are audible, Bhavik. You can share your screen.
Yeah. So, Dr. Sohaib, if you can allow me to share your screen, we'll come to your pictures, Fundus pictures after some time.
Yeah. So if you can just stop sharing. Yeah, very nice. So we have crossed 30 participants. That is excellent response which we have got.
Okay, so what I want to share here is that in this image, okay, so first of all, before going to that point, this is the question here. What is the difference in the size of a microaneurysm between the BRVO and the diabetic retinopathy? As you all mentioned that both these conditions, we can have microaneurysms. So now, is there a difference in the size of microaneurysms between a vein occlusion and a diabetic retinopathy? Let's find out. Can anyone describe this photograph? Anyone wants to volunteer and describe this photograph?
Maybe Dr. Ashwini, can you take it? Dr. Prasanna, would you like to take the question? Anyone can volunteer? Dr. Iris?
Okay, I will describe it.
Okay, yes.
This is a frontal picture of left eye with the normal disc color and margin with superior inferior arcades are normal, unremarkable. There is exudation in the peri and parafoveal region with looks like edema in the macula as well. That's what I can see. There is a succinate pattern of exudates near in the perifoveal and parafoveal region.
That's wonderful. Yeah. So can you note? Okay, fine. So this is one image. Now let's go to the next image. Now, can you make out any changes here, or is this image better, or what more things you can find out in this image?
It looks like hypertensive changes, mild hypertensive changes in retinal artery, like, and no, I cannot appreciate much.
Okay. So what kind of imaging modality is this? Can anyone answer? So there's nothing to be worried that if we are right, wrong, we're all here to learn.
It's red-free. Red-free image.
Very good. Very good. Okay. It's a red-free image. Excellent. So now from compared to this previous image and compared to this image, what is the change you see is much better seen or appreciable? I want you guys to think.
Vessels.
Retinal fiber.
So, Dr. Asma, you can be a little louder.
RNFL, sir.
Anything else?
So can you guys see this? What are these dots here? 1, 2, 3, 4, 5, 6.
Sir, hemorrhages.
Or can it be microaneurysms?
Microaneurysm.
Right. Okay. Now we'll go back to this image. Are they seen here can you see those images again now? Those dots. It's difficult to observe, right? So this is a very important point, that always use the red-free light. Okay. It gives you a better appreciation of the hemorrhages. It helps you rule out diabetic retinopathy. It's a very simple way to screen a patient for diabetic retinopathy. Just change from that normal light, LED light, to a red-free light. Put a red-free filter in your indirect or your sit lamp.
One point, Bhavik, I'd like to add.
Yeah.
Also, like, especially when you're starting, this red-free light is little tolerated better by the eye. So if you're in your starting days and you take a lot of time, so if you see all these patients in a green light, then also you will see better.
Yes. Okay. So patient-friendly light and okay. So the next question is that there's a very common question in viva. Why does this red-free light gives a better appearance of the hemorrhages or anything which is red in color? Why do you see these changes in a better way on a red-free light?
It probably masks the choroidal glow which is seen.
Okay. Any other simpler answer?
It gives a more contrast.
Excellent. Yes. Okay. It's a very simple way to answer. It just provides a better contrast. Okay. Now, since we have identified that we have aneurysms here, and we have this succinate retinopathy, and we have few aneurysms in the center as well. So make out these changes. Look at the changes in the size of the aneurysm, what you see here, and in the center. Right. Let us go to an angiogram of the same patient now. Now we have this aneurysms which are quite larger in size compared to the aneurysms which are much more smaller. So what do we learn from this? That in the patients with vein occlusion, the size of, especially BRVO, size of a microaneurysm is much more larger compared to that of diabetic retinopathy. Okay, so in a patient with diabetes, if you see two different types of aneurysms, suspect that this patient can have associated vein occlusion as well. Is this point clear to everyone?
Yeah, that's a good point.
Okay.
But why there is a difference of size in BRVO or vein occlusion?
I do not know. Maybe I think it's related to the amount of hypoxia which is there. Amount of hypoxia will be much more in this patients with vein occlusion.
Or
Like,
can it be can there be a reason like there is a more backflow pressure?
It's possible. I do not know the details of it. This is just an observation which came across.
Okay.
Sir, could you repeat the point? Why there can be combined vein occlusion with diabetic retinopathy when to suspect?
So when you have two different types of microaneurysms in the same patient, two different sizes, okay, and you see larger microaneurysms and smaller microaneurysms, suspect that the ones which there are larger microaneurysms, an area of vein occlusion might be present there. Okay. And when Dr. Sohaib mentioned about CRVO being there as well, in CRVO the microaneurysms are extremely small in size. Like we may not see them actually. So it's very rare to see microaneurysms in patients with CRVO.
Okay.
They are present, yeah. Okay. So that was the point which I wanted to make. Now, on similar lines, I have another question for all of you. So what we saw was a patient with two microaneurysms will classify as mild NPDR. So what is moderate NPDR?
There is a microaneurysms or hemorrhages, and there is also cotton wool spots. No, mostly hemorrhages and microaneurysms are
20.
Correct. Okay. So now say this patient, there's one more patient who has only two microaneurysms and has diabetic macular edema. What will be the classification for this patient?
it is classified in CSME, in clinical significant macular edema.
That is fine. That is for the macular edema. Will it be mild NPDR, moderate NPDR, severe NPDR?
No, it is still mild NPDR, I think.
Okay. Does anyone differ, or has anyone to add? Does anyone wants to add to this? So the question is very simple. Patient has diabetic macular edema and has only two microaneurysms. How will you classify this patient? As mild, moderate, severe NPDR?
Diabetic macular edema can appear in any of the forms of severities of NPDR, mild, moderate, or severe. They are two different things, I think.
Okay, this is a very important point which I want to drive. Saying that DME is not a criteria while classifying diabetic retinopathy. In a patient with mild NPDR can also have DME. Okay. So most of the time we forget this. We see DME and we write as, okay, this is moderate NPDR, severe NPDR. Or sometimes we just don't want to, we say this is pseudophakic CME, even because the patient only microaneurysms. Okay, this is very commonly being seen. So we have to be aware of this, that patients with the diabetic macular edema is not a criteria while classifying diabetic retinopathy. Okay. So now let us do one thing is let's go ahead with okay, what are hard exudates?
The hard exudates are actually the lipids which are leaked into the retina due to the leaking vessel. And when the edema resolves, these hard lipid particles remain in the retina. And this is that's what we see as a hard exudates.
They are the macrophages which engulf the local lipids and they aggregate together to form the hard exudate.
Yes, it's
in the
not
outer
just
plexiform layer.
Perfect, very good. It's not just the lipids. Okay, whenever someone asks about hard exudates, it is a mix of both the macrophages which are engulfing the lipids as well, plus lipid as both. Okay. So they are deposits of extravascular lipoproteins and lipid-filled macrophages in the outer plexiform layer, as rightly mentioned by one of the participants. Okay, so similar question now compared to what we discussed with the microaneurysms. What are conditions you see hard exudates? Just enlist the conditions. Some of you can write it, some of you can say it as well.
In hyperlipidemic patients, there is more exudation.
Correct, very good. I'm asking is, apart from diabetic retinopathy,
Okay.
Which all conditions you can see heart exudates?
In macroaneurysms, you
Okay.
can see, or
Then what else? Anyone else?
in CNV.
Hypertensive retinopathy.
Hypertensive retinopathy, yes. Retinal artery macroaneurysm, yes.
Any neuroretinitis.
Neuroretinitis, yes. Okay, Coach disease, isn't it? FEVR. So basically what you understand from this example is that all those conditions where there is a vascular compromise, you get extravasation of the lipoproteins, okay, and lipid-filled macrophages. So whenever you see heart exudates, you have to understand there is an underlying vascular compromise which is happening. Okay.
Okay.
Yeah. So fine. I'm just thinking of what all points we can think of. Okay, let me just share another slide now here, since we're talking about heart exudates. Okay, what do you guys see here in this slide? Can anyone describe this image?
This is a fundus photo of the left eye with disc normal, blood vessels appearing normal in caliber and distribution. At the macula, there appears to be a yellowish, hazy kind of a lesion with blood vessels going underneath it. So, and it looks elevated. So probably there can be a macular edema. And along the superior arcade, there appears a yellowish, well demarcated kind of lesions which are clumped together. Probably they are heart exudates.
Correct. Okay. So now the next question here is that maybe the last question for this slide. When you see such a case, what will you do next? So the point is that you always look at the periphery. Okay. So you may have a vascular compromise, be it FEVR, codes, or even a retinal angioma, and that can lead to such kind of exudation. Okay. Yeah. So maybe this one point some of them have raised in this thing about the angiogram of an FFA, or angiogram of a microaneurysm. So can anyone describe the angiogram for a microaneurysm, or how do we know that? How do you see a microaneurysm on an FA?
Sorry, I can't get your question.
I'm saying that how on an angiogram, how will a microaneurysm look or appear?
The leak starts in the early phases and progressively enlarges the size of the leak.
Good. Okay, so there will be a hyperfluorescence, a white color lesion which will be seen. That is the hyperfluorescence will be noted. Right?
Yeah.
So the microaneurysms will be leaking, and there won't be much increase in the size, but definitely the intensity will keep on increasing. This is how we identify a microaneurysm on a
recording in progress.
On an angiogram. Okay. So Dr. Sohaib, if you can go back to your case, if you can share your presentation after
Yes.
finishing basics of knowing the exudation, heart exudates, and microaneurysm, we'll go back to your case and identify this case of PDR and what we do with this patient next. Okay, so now you have already mentioned that you send this patient for lipid profile and for the systemic stabilization of the diabetes and all, right? So suppose this patient comes back to you and saying that all blood tests are normal and all. So now for this patient, if you go to the fundus image here for the right eye.
Wait a second.
Yeah.
Okay, this is a fundus picture of right eye.
Okay. So this patient you are seeing in the OPD for the first time, right?
Yeah.
Okay. So now for everyone's benefit here, how will you go about counseling this patient? So what we have is right eye is the vitreous hemorrhage with the disc which is seen. Okay. Disc is hazily seen. You go to the left eye image as well.
Yeah, this is the left one.
Yeah. So what are the findings in the left eye, first of all? We see
Well,
the laser, as you mentioned.
there is a laser mark on temporal as well. Actually, it is 360, but in this picture, these marks are visible on temporal side and also on supranasal side.
Yes.
And there is also NVEs, which are present in supratemporal and infratemporal region of the arcade.
Correct. So
And
if we look carefully here, anyone else wants to add to this photograph? What you see?
There is a shallow TRD along the inferior arcade. FVP, fibrovascular proliferation causing traction.
Correct. Okay. So if you can, doctor, so if you can trace out, you can see the vitreous which is going and attaching to the infratemporal arcade.
yeah.
And if you see there is a NVD, I feel there is an NVDA as well. If you look at the orangish hue around the optic nerve, okay, I don't know, I cannot mark it here. If I can.
Yeah, there is this region, I think.
Yes, correct. Okay. So that is one thing. Second is there is a sclerosed vessel. If you see in the superiotemporal arcade, inside within the arcade itself, superiotemporal area.
This one.
The sclerosed vessel which is going from within the arcade, superiotemporal, temporal to the fovea.
This one.
No, if you can trace below that, if you can trace the vessel.
This one?
No, below it, on the temporal to the fovea.
This one?
Yes.
This is
right.
This is not the vessel. It is, I can say, it is a tractional element or fibrous element that is attaching to it.
Yeah. It appeared as a sclerosed vessel. Yeah. So now the point is, how will you go about management for this patient? What will be your next step? This one eye has vitreous hemorrhage with hand wound vision, diminished vision for 10 days, and left eye is 6/36 with post-PRP marks, but has NVE, NVD, and an FVP as well, the fraction of the vitreous condensation which is present inferotemporal to the fovea. So
well, for with OCT, we didn't find any tractional element in this patient. Okay. So I would like to start with the anti-VEGF.
For the right eye, for the left eye?
For the left eye.
Okay. And for the right eye?
For the right eye, still, I would also start with anti-VEGF as well.
Before that,
first we need to do a B scan for the right eye to exclude the traction before giving anti-VEGF.
Yeah, there is no traction element in that eye as well.
Correct. Okay. So that's a very good way to approach. So first of all, what I want to impress upon here is that whenever patients with sudden onset vitreous hemorrhage, diabetic patient comes, especially who has been treated, given anti-VEGF or post-laser and all, we should not panic. Okay. And we should also counsel the patient that do not worry. In the life of a diabetic, multiple occasions will come where even after sufficient laser, even after anti-VEGFs, a vitreous hemorrhage can occur. Even after vitrectomy, in a vitrectomized eye as well, a diffuse VH can appear. So the doctor should not panic. Even the patient should be consoled and reassured. That is the first step. Okay. So now the next step here is that doing a B scan. As you also mentioned, other participant mentioned that we have to ensure that there is no fraction anywhere in the retina. If there is no fraction, we can safely go ahead with the anti-VEGF injection. Okay. If at all you want to wait for 2 weeks, if it's a vitrectomized eye, you can wait for 2 weeks as well and see. Sometimes, like in your case as well, the disc is seen easily. There's nothing wrong in waiting and seeing up for a period of 2 to 3 weeks. Sometimes the vitreous hemorrhage clears on its own. Okay. Yeah. That also helps in terms of managing the patient. Yes. And that is for the right eye. So I would also agree with you, going ahead rather than surgery directly, we have a chance of anti-VEGF, trial of anti-VEGF to the patient. Now in the left eye, So left eye, we see that there is an NV, there is a tractional component in terms of vitreous condensation, which is present inferotemporal. Okay,
Yes.
as some of the participants mentioned in the chat box as well, definitely an AD laser is required. For such patients, we can actually come closer to the arcade as well. And between the PRP marks also, some more laser can be added. Okay. Right.
But if the macula is threatened, like in this case, there is a tractional element which is close to the macula, should we apply laser or should we straightly go for a PPV?
No, so that's what I'm trying to say. PPV at this point in time, it's very clear the indications of diabetic. So that is what brings me to this question. What is the DRVS study? Can anyone explain what is DRVS study?
It is a study for vitrectomy in diabetic patients, and it said that vitrectomy is better than I think it is compared with injections.
So when was the study done? How long back?
I don't know about this.
1976.
Okay.
So and when have the injection started?
20-30 years ago.
So not in
And
India at least.
Yeah, maybe in Pakistan, I'm not sure. But in 2004 was the first time we started using bevacizumab. In 2003, we started using Macugen, pegapinil. Okay. So even the ETDRS study and all, there was no anti-VEGF at that point in time. That is why drcr.net has come with newer protocols.
So maybe someone else can talk about DRVS and how that can lead us to management of this case, as Bhavik was discussing. Dr. Bushra, would you like to take? Or Dr. Neeta? Anyone else? Dr. Iris?
Well, DRVS study says that vitrectomy in vitreous hemorrhage, early vitrectomy in vitreous hemorrhage is more beneficial for the eyes. Yeah.
In which type of diabetes?
Type 1.
Type 1.
Excellent, excellent.
Yeah. And in drcr.net study, the protocol D says that early vitrectomy is more beneficial for these eyes. So vitrectomy can be a possible management or mode of treatment for this patient. What's your say about this?
Yeah. So just before that, someone has mentioned here that if TRD there, anti-VEGF followed by vitrectomy surgery and endo laser after 5 days. So if at all we are going for surgery, we finish the laser during the surgery itself. Okay. There may be possibility that endo laser may or may not work, or sometimes it's not available. That's a different scenario.
I think they meant is surgery and endo laser after 5 days, both together.
Oh, okay. Sorry.
5 days of anti-VEGF.
Yeah, my bad then. Yeah.
No, it is maybe better grammar.
Okay. Sorry, my bad for that. Yeah. Okay. Yeah. So other reason is, was there any macular edema for this patient on the OCT, Dr. Sohaib?
Yeah, there is macular edema as well.
Okay. Yeah. So for the left eye, definitely an anti-VEGF will be a good choice here. Okay. Along with fill in PRP, add in PRP. Only concern with the anti-VEGF is that you see the inferotemporal traction which is there, right? The vitreous condensation. Sometimes it can lead to a traction which may progress to involve the macula as well, the fovea as well. That is only concern. So rather than that, a safe approach would be, especially if this was a one-eyed patient or the other eye vision is low, is to give in intravitreal steroids, an Ozurdex or a IVTA injection, the intravitreal triamcinolone acetonide, and to add fill in PRP. That is another way to deal with this kind of patients.
Sir, I have a question. Suppose in this eye there was a frank TRD or suppose a secondary reg RD, like a combined RD. In that case also we should have, can we give anti-VEGF followed by 4 to 5 days later PPV, or anti-VEGF is totally contraindicated if there's a break?
No. Anti-VEGF is not contraindicated if there's a break. See, if you're planning to operate, always better to give an anti-VEGF and operate in diabetic patients. Okay, such vascular eyes, if you have a large NVD and all. Then talking about if you're not planning to operate, like in this case, the macula is not threatened as of now. Okay, so that brings to the next question here. What are the indications of surgery in a patient with diabetes or PDR? That is a better question.
Persistent vitreous hemorrhage or any tractional retinal detachment threatening the macula or any combined RD.
Okay, so the major indications are non-clearing vitreous hemorrhage. It's not just vitreous hemorrhage. Like what we have in the right eye also is vitreous hemorrhage. Right? We are not going to go and operate. So non-clearing vitreous hemorrhage. Fractional
Persistent,
retinal.
persistent for 2 to 3 months.
Yes. Okay. Fractional retinal detachment. So that is also a very tricky situation now. Persistent of 2 to 3 months. Now, suppose there's a doctor and or a driver. You can't wait for 2 to 3 months, right? Where they need their vision is very important. So that depends on the patient's profession as well, right? So that is something which need to consider. Or so non-clearing vitreous hemorrhage, fractional retinal detachment, and a combined retinal detachment. And less common indications are macular edema with a thickened and taut posterior hyaloid, taut pre-retinal macular hemorrhage, or a sub-IRM hemorrhage, extrafoveal traction with vision decrease due to foveal ectopia. There's a drag on the fovea, but the fovea is not detached. So that can also one of the reason to operate such eyes.
Okay.
Okay.
And if there is a persistent macular edema with even with the anti-VEGF and steroids.
Yes, definitely that can be a last resort.
Yes, true. Okay, and one more thing is that if the vision is not correlating, especially in this case as well, better to get an OCT angio or an FA done to identify for any macular ischemia as well. Because if you look at the optic now also, it appears pale. Isn't it? I'm not sure if the photograph is over.
No, it's on police side, but it is mostly due to a photograph.
Okay, fine. So another reason for persistent neovascularization in patients with diabetes is inadequate PRP. So we need to come closer to the arcades in such a situation. Something called as tight PRP is a word used here. Like if you look at the temporal laser marks here,
There's a gap
added in between them as well. Okay, especially in this patient. Okay, and there can be persistent traction, which can lead to neovascularization. Like we have that point here as well. Inferiorly, you have the traction which is there. So that vitreous will always act as a scaffold, like a bridge for the neovascularization to come and form on that. Okay, and third point is if the patients have persistent neovascularization, is anemia again. Patients with anemia can have persistent neovascularization because of the chronic hypoxia which is there. So these are three important points which can lead to persistent neovascularization, patient diabetes mellitus, in spite of undergoing PRP.
Okay.
Okay. Yeah. So how will you counsel this patient now?
So first of all, I will tell not to panic, as you said this, and the strict hypertensive glycemic control, lipid control is very much part of a management for future as well, because if she remains a poor compliant for her diabetes, then this issue will recur time after time. So the strict control is
lipid control going to make a difference in our case?
Well, according to a court study, the risk factor, lipid control is also a risk factor for worsening of diabetic retinopathy. So we have
retinopathy and anything else? Which particular cases you are more interested in looking for the lipid and want to lower them?
Vein occlusions.
No, in a case of diabetes?
In type of diabetes?
No, what should be there in the fundus?
Exudates.
Yeah, so it is macular edema per se, which is very important. And even if the cholesterol or the lipids are not on the higher side, you may still start lipid lowering to reduce the edema.
Okay.
Yeah, go ahead. You were managing the case.
Sorry.
Yeah, Dr. So you mentioned that do not panic, reassure the patient. Then what else? Systemic control of the patient. Yes, correct.
And then I will, for left, I will go for, first I will go for anti-VEGF, and on OCT, as there is a tractional, there is no tractional element. So I will do PRP 2 weeks after anti-VEGF as well. So I will consecutively give anti-VEGF and PRP with the interval of 2 weeks.
Okay.
Okay.
So
Yeah.
there is no fixed protocol as such. Like in this patient, you can also do PRP at the same time, and the patient has come to you, and you can also schedule an anti-VEGF. Okay. And even for the right eye, people are mentioning that once the VH clears after anti-VEGF, we'll do PRP. So again, with protocol S, with drcr.net, in the exam, you can stick to this answer. But if the examiner prompts you with protocol S, we can use only anti-VEGF as well to manage diabetic retinopathy patients who have good systemic control and who can follow up properly. Okay, on time. So what I wanted to answer or inform one more point is that in terms of counseling the patient, very important to explain the patient that 3 sittings of PRP, 2 injections, 3 injections is not enough. Okay, so you should never say this, I'll give you 3 injections, 4 injections. There is no end to it. We do not know how many injections the patient will need. Same way, how many sittings of laser is required, again, we do not know. It's very important to counsel the patient that diabetic status or have maintaining a good diabetic mellitus status, control of blood sugar along with hypertension, extremely important. That is the primary treatment for non-progression of diabetic retinopathy. And for the treatment of diabetic retinopathy, they have to come on time, and proper follow-up is required, compliance is required, and they may require multiple sittings of treatment, be it injections, laser, okay, or may require surgery also, in spite of multiple injections and laser. This is very important because a lot of time patients come back to us in the clinic, say, you've already done 3 injections. How many more injections will I require? Will I need? My vision is not improving. So that is very important to counsel the patients. Dr. Anuj, you agree with this? You want to add?
Yeah,
Yes.
yeah, absolutely. Just from a resident point of view, it is very important for you to know that, as Dr. Bhavik said, that protocol S we rely on if we want to give anti-VEGF. So it is important for us to know, and we should be who told us that we can do laser in this and it will work? How did we come to know?
TDRS.
Which study in this case? Anyone else?
ETDRS told it is a study from.
No, before ETDRS, there was one more.
DRS gave the criteria for high risk PDR.
Absolutely. So in case of proliferative diabetic retinopathy, it was the DRS study. And what was the conclusion of that? If you do a PRP, what will happen?
What will happen in retinal point of view?
What was the conclusion? If the patient asked, after this PRP, will I start seeing better?
Photocoagulation reduces the risk of severe visual loss by 50%.
Absolutely. Absolutely. So this is for exam point of view, and even both theory and practical. There's severe vision loss. There is a reduction in risk of severe vision loss. Okay. That is. And what did the ETDRS say?
ETDRS is say about sphere NPDR actually.
Yeah. So what happens?
That the progression to PDR from sphere NPDR will reduce with I think 50%.
Reduction in the risk. It is always the reduction in the risk. Okay. And what was the laser use?
Organ laser or double ND. Yeah.
No, again, it was argon laser. So which argon laser was used?
Yellow green.
No, not yellow.
Green
and there was one more laser used, which we don't use now. Before green, what wavelength we get?
Blue.
Yes. So we use the blue and green, and we found that blue laser is harmful because we were doing even in ETDRS. What else was there even other than PRP?
It said that scatter treatment is not indicated for eyes with mild to moderate NPDR.
Very nice.
It's only indicated for severe NPDR and PDR.
Okay. And what else did they study?
Focal photocoagulation recommended in CSME.
Yes. So they studied both blue and green, and they found that blue laser will be harmful because it is absorbed by the xanthophils. So hence after that we started using green laser. Okay. What was the laser we used in DRS?
I think same organ laser.
No, because it was a much earlier study. So we were using xenon arc.
Xenon arc. Okay.
And argon blue also, I think, in the end, and they found that that was better.
Okay.
So these are some historical and these are landmark trials. So at least the gist of it and the conclusions should be very important. So what did the ETDRS say for the macular laser? What was the conclusion? If we do laser, what will happen?
There
It
is
reduces the risk of moderate visual loss.
Yes, again, it is very important that not to say that there will be visual improvement, but the risk of vision loss, okay, is reduced. Okay, not severe visual loss. Okay, I think it was 2 lines or that some visual angle is there. Maybe Dr. Bhavik can add more on it.
Sorry, can you tell the question again?
Yeah, so it was moderate visual loss. What was the definition? I think severe vision loss was 5/200, I think something, and moderate vision loss was, I think, 2 lines, or maybe you all can read.
Yeah, I think we'll have to get back to, because such things are very volatile. It's very important that you revise this before the exams, because even you keep on reading, and since we don't practice it much, especially the older studies, right? Yeah.
Yes, Bhavik, you can go ahead.
Yeah. So any other questions? Like, these are the points which I wanted to mention about the case as well.
Sir, I had a question.
Yes.
Suppose this is a treatment naive pseudophakic eye with PDR and DME. So in such case, would your first modality of management would be anti-VEGF to improve the vision, followed by PRP, or you would do PRP first and then give anti-VEGF, because PRP will again aggravate the edema and anti-VEGF can take care of both?
Yeah, so that's what I'm trying to say. I mostly follow protocol S for my patients. Okay, lot of factors are to be considered. Say a patient pseudophakic or a phakic patient has macular edema and has PDR in treatment naive. So first and foremost will be systemic control itself. I'll not go ahead with the treatment right away on the same day, because a lot of time I spend with my patient counseling them, making them understand what is the disease first of all. Because a lot of them do not understand that the eye and the diabetes are connected. And if you don't spend time with your patient for the first time, they'll always keep on asking you these questions that, doctor, you have treated me for so much long time, so much of my money has been spent, but I have no improvement there. So one should spend a significant amount of time, especially for the first visit, explaining the patient the disease nature. Then they'll only understand. So once they start controlling the diabetes and their HbA1c comes back to below 7 or around 7, you will see that there is not much need for injections in the future compared to injections in the first 6 months or the first 1 year versus the second year, third year. Number of injections goes down significantly. Okay, and if the patient's sugars are under control, DM status under control, you may not require multiple treatment of lasers for such individuals as well. Answering your point, I'll treat that patient if there is no traction component at all and only PDR with few flat NVs and diabetic macular edema, only with anti-VEGF first. I may not go ahead with laser PRP as well for such patients. If they are able to follow up, they are from local area and who can come to me every 3 months, 4 months for their visit, as in when I call them, I may not go ahead with.
Sir, even
PRP
if there is a proliferative component, still you will not go ahead for PRP after anti-VEGF also?
Yes, I'm talking about PDR patients only.
Yes, okay, sir.
This is
And
what
sir,
protocol mentions, and this is what we follow as well. But now there is a catch as well. Say a patient who comes from other state to me or other district or other city from to me and cannot follow up regularly, or his job requires so much of travel that patient may miss the visits and all. Better to go ahead with PRP for such patients. So in that case, I'll give anti-VEGF first and then go ahead with PRP after the first anti-VEGF.
okay, sir. And
So
sir, last doubt, sir. Suppose what is the rationale for combining any anti-VEGF with IVTA, like based on the OCT? If there is any neurosensitive detachment underlying the edema, do you combine IVTA with that, or what is the rationale? And what is the combined volume of the two injections when you are giving?
Yeah, so I don't think there's rationale for combining both together, especially IVTA. Some people can combine, not combine, but do one after the other. Say, for example, patient is going to US or some other country. I'm going to come back to 6 months. So you can give an anti-VEGF. 1 week later, you can give an Ozurdex or an implant or a steroid implant. This is what certain people practice if the patient is not going to follow. But if the patient is going to follow up, you don't have to combine the two injections at the same time. You give one injection first. Okay. Say, for example, now in your case, if there is a neurosensory detachment or SRF, okay, but not much of exudation, I'll go ahead with anti-VEGF. Okay, but now what happens sometimes, there is a lot of exudation in the perifoveal region. And if you give anti-VEGF, because of sync effect, all the exudation is going to come to the center in the fovea. So patient's vision is going to drop down. In such a scenario, you can go ahead with a steroid injection. The steroid injection does not lead to a faster progression or faster resolution of exudates. Basically, steroid has anti-VEGF has a much more drying effect compared to steroids. Steroids take a little longer time. That allows the retinal pigment epithelium to absorb all the exudation and throw it back into the systemic circulation. So the exudation does not come to the fovea and there's no vision drop for the patient. You got my point?
Yes, sir. Thank you.
So there is a question I want to ask.
Yeah.
You said that in the case of PDR like this, and if the patient is local and he or she can come to a follow-up regularly, you will go for injection alone, but not laser.
Yes, I'm not saying such
But-
kind of patient. This patient, I'll definitely go ahead with laser. But a patient who has just 1 or 2 NVs in the periphery, early PDR, right? 1 or 2 NVs in 1-2 segment, then I will not like to laser the entire retina, because lasering the retina also has own side effects, right? Peripheral vision is reduced, night vision is compromised.
But only giving injection isn't it temporary treatment or effect?
No,
At the end.
along with a good systemic control. That's why I said first is good systemic control.
Or can we say that in early PDR we can give only injections?
Yes, definitely. Yes, that is what Protocol S also mentions, right? So we have evidence for it now. So again, it's like I explained. We can explain to the patient. Some patients are aware of it. They also go on Google. They also read a lot of things. But if you think patient is not going to maintain, if it's a one-night patient is not going to maintain sugar levels are not under control. Patient has associated nephropathy, has a lot of other systemic complications. There's no point discussing also with this patient, such patient. Better to go with laser altogether. We're talking about certain set of patients can benefit out of it.
So I think what Dr. Bhavik means is that there is an option where you can go without doing laser. It is not that if you do laser for a patient with PDR, it is wrong or it is outdated. Now, after Protocol S, there is an option where you can just follow up with injections. And as he has nicely pointed out, the criteria, which cases you should go, who have good systemic control and who are educated and understand the pathology and are going to follow up with you. You know, some patients will laser and they will come back after 1 year or may not come back to you. So when you feel there is such a patient, you may not like to give an anti-VEGF. You may instead like to do a laser. Depending on the age, depending on, see, as he has said, the protocol S has showed us that this treatment also works. And it is not a one-time treatment, as you said, temporary. Yes, you may have to repeat the injections. Yeah. So explaining all the pros and cons, it is an option which you can give to the patient if he can afford, if he feels that that is a better option. Because as he said, laser is a little more invasive. Okay. May not be a correct word using invasive, but it really leads to problems like field loss, and sometimes it can be painful also, and the repeated sittings in a month which may be needed. So all those things, some patients may opt for a anti-VEGF, and the option is in front of you. So you can choose according to your comfort level.
Okay, I know. Like we can delay the time of laser if we find that the patient is compliant and is educated and can control the diabetes.
Absolutely.
Yes, surely. Yes, yeah.
Okay.
So one comment has come that can you please repeat causes for symmetrical DR? So systemic causes for symmetrical DR are anemia, as I mentioned, a patient having hypertension, nephropathy, diabetic nephropathy, patients having leukemia, like radiation retinopathy. It can worsen the diabetic retinopathy and it will be symmetrical.
Okay, one more point for asymmetric DR. There are no criteria as such, but generally it should be more than 2 stages ahead. Like a severe NPDR and a PDR, you will not call it as an asymmetric DR, right? Okay, but a very mild NPDR or mild NPDR and a PDR, you can definitely call it as an asymmetric. But there is no fixed criteria that there should be no diabetic retinopathy in one eye, and a PDR or a severe PDR is asymmetric DR, because there is no criteria as such. But it gives you a clue that you may have to look for the local and systemic pathologies as listed out by Bhavik. Okay, and what is the name of the syndrome, or what is the condition if you give anti-VEGF in a case where there is a TRD?
Crunch syndrome. Crunch syndrome.
Yes, so that is also important for your viva. You may be asked about it. I think if there is any other doubt anyone wants to ask, because Dr. Bhavik is really busy and we have to really let him go. On his Sunday, he has taken out time from his busy schedule.
Thank you, Anush, for being such a considerate person.
Sir, I have a question, sir.
Yeah,
That if there is a pre-retinal hemorrhage from an NV and there is a diabetic macular edema on the first day of presentation, so then will you be doing a laser on that first day itself, or just going for again systemic control and injection and then go with laser?
So again, I would like to say the same thing, that it's important to understand that if the patient is coming for the first time, it's the first day for the patient. The patient also is scared, right? And you straight away tell them, no, you need this injection, which is 10,000 rupees, 20,000 rupees, and you need to have to undergo laser. They also will be scared. So a strategy is that you counsel the patient, explain them the condition, give them the blood test, let them come back after 4 or 5 days. Okay, in 4 or 5 days, nothing is going to change for the patient, or the world is not going to go upside down. You will gain the trust of the patient. Patient also understand. You will also understand the systemic profile of the patient. You may be surprised. HbA1c, we have patients with HbA1c of 12, 13. Okay, and they are not even aware of their, okay, my sugars need to be under control. Isn't it? So that is one thing. If the patient already been referred from somewhere and comes to you, patient is aware of it, then you can go ahead with anti-VEGF on the first day itself. Okay, or whatever schedule after 1 or 2 days. And once the VH or the, so now in your question, if there is pre-retinal hemorrhage, but there is no VH, you can go ahead with laser on the first day and give anti-VEGF as well. If there is DME. If there is no DME, you can just give you can start laser as well, infrared laser for the patient. Because you have to realize that the pre-retinal hemorrhage is going to undergo a breakthrough and inferior VH is going to happen. But if there is associated vitreous hemorrhage and you can't do laser, Sometimes superior retina is visible. You can do laser to superior retina as well. But you can add with the anti-VEGF as well. There is no fixed protocol. It's an individual basis and case-to-case basis, whether you want to use anti-VEGF along with laser or laser first and anti-VEGF later. Those things are variable. But what is not variable or what is fixed is patient systemic control needs to be managed.
So what Dr. Bhavik wants to make it clear is that all these studies have told that you have time in these cases. So it is not that the patient has come to you today and you have to treat him today only. So it is very important here to you see the patient as a whole, and sometimes you may even miss other systemic findings, okay, which may be even more threatening. Okay, at times the blood pressure may be too high or the kidney status may be very bad. So all these things you have to take care, and there is a component of natural history as well, which may take care of this episode, and the future episodes may be taken care by doing a laser or an anti-VEGF. But you have a period of time. So if you are unsure or if you cannot, it is not a even medical legally, it is a correct treatment. That is what he is trying to tell you, that you should take your time and treat him as a whole and not just look at his eye. So Soeb, anything else?
What about if a patient with pregnant lady with a PDR cane? What will the mode of treatment? Can we give anti-VEGF in that case?
No. That would be a strict no.
No, that's a very good question. Okay, now in that also has multiple because it's a very practical question, right? And
Excuse me. Let's add one point also to discussion. What is the screening criteria for diabetic retinopathy in pregnant females?
So what you're trying to ask is that, so in this, one is a lady who is already diabetic and undergoes or conceives. That is the first point. Our second point is patient who is not diabetic and now has gestational diabetes mellitus. So a type 1 diabetic who undergoes a pregnancy, you have to be extremely careful and you explain them that you need to have a good sugar control. Because because of the hormonal imbalance and a lot of other factors, the diabetes is going to worsen. They should be counseled, okay, and if required in the severe NPDR stage or in the early PDR stage itself, if that stage is present, you may have to go with the PRP for them. If the patient does not have diabetic retinopathy changes, you can just observe and call them every monthly as well, for that matter.
Okay.
For just a fundus evaluation. Okay. Now, the second scenario, a patient who was already diabetic and has developed vitreous hemorrhage now. Okay. So, whether if there is vitreous hemorrhage, a patient of PDR and she's diabetic. So, whether she has VH or no. If there is no VH, just go ahead with PRP and do a nice tight PRP for them. Okay. Second thing is that if there is vitreous hemorrhage, if any retina is visible, I'll do laser to that area. Because by doing laser also, VH is going to reduce. Okay. Occasionally, there might be a call. So ideally, as Dr. Anuj mentioned, anti-VEGF should not be used because there is no study which has proven saying that there is benefit or no benefit or which is harmful. But then there is no evidence saying that this is safe in pregnancy. So no one's going to take that call. Okay. So if not, a surgery also is an option for such patients and doing an endo laser at the time of surgery if they are in their early pregnancy. So it is a difficult situation. It is a tricky situation depending upon the other eye status and all those scenarios are there and how far it is from the pregnancy. When can the child be delivered and after that you can manage. So it is again a case-to-case basis. There is no one such answer for such a scenario.
Okay. Thank you for that.
So let's call it a day.
Yes, thank you, Dr. Anuj, for inviting and giving me this opportunity. And thank you, Sohaib, for taking out time and actually presenting a very nice case. And thank you to all the participants.
Yeah, thank you to you all for discussing this case. It is a generally and most general case, but discussing a different point of view is very beneficial.
Sure. Hope it was helpful to all. And if any doubts you want to ask Bhavik, you can just post it and I'll share it with Bhavik and get back to you. Okay.
Okay.
Yes, and thank you to Clinical
You can
Peanuts in
email Bhavik
Ophthalmology.
directly.
Yeah, and I'm saying thank you to Clinical Peanuts in Ophthalmology. Everyone should subscribe it. Wonderful channel. Lots to learn from that.
Okay, thanks for the
Thank you.
endorsement, Bhavik.
Thank you.
Okay. Chalo,
Okay,
good
bye-bye.
night.
Good night. Yeah.
And thanks for sparing the time, Bhavik, and thank you everyone.
Okay. Thank you.
I hope this link is available on YouTube. I'll see. I tried it, so if it is there, I'll share the link with everyone.
Okay. Thank you.